5, 4, 3, 2.
Good afternoon, my friends. The doctor is in the house, and welcome back to another episode of To Your Health with Dr. G. My name is Dr. Mark Gomez. I'm a practicing internal medicine physician, board certified with Edward Hospital out in Naperville and Bolingbrook, Illinois. So welcome back. So to give everybody kind of a recap of what this show is all about, each week I interview a panel of my esteemed colleagues and experts on various health topics, and we just talk about what's out there, what are some of the new trends, what are some of the approaches for patients as well too. So today is going to be part 2 of Obesity Wars. Now, last week we did part 1 of Obesity Wars, and we talked about just the problem at hand, the epidemic aspects of obesity and ways to approach obesity treatment worldwide. And of course, to refresh everybody's memory, obesity is a problem that affects many communities and is a big public health burden. So this week on part 2, we're going to be talking to some of my colleagues, and I kind of call them the proceduralists. But these gentlemen here have years of clinical experience and a unique approach to dealing with the obesity epidemic. Before we start and everything, I want to hit you guys with a quick disclaimer as usual. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and or treatment. Further details can be found at https www.toyourhealthwithdrg.com/disclaimer. So again, welcome everybody. Again, my name is Dr. G. You can follow me on Facebook, Twitter, and Instagram at To Your Health Dr. G. We are very pleased to have everybody here today. And what we're going to do today, everybody, is we're going to talk about Obesity Wars Part 2. And in particular, we're going to be talking about the procedures that are out there, from everything from surgical procedures to endoscopic procedures to even cosmetic approaches. And all these kind of approaches that we're going to talk about today complement the lifestyle changes that are essential to conquering obesity and meeting the challenges that face our communities at large. So, I'm going to introduce my guests in a few moments, but I want to just kind of start with how does obesity affect me in my practice. As a primary care physician, I certainly see the challenges of obesity on a daily basis. We know from a statistical standpoint that the obesity epidemic is just growing bigger and bigger. In the USA, 37.7% of adults have obesity, 7.7% of adults have severe obesity, and that's defined as a body mass index greater than 40. There's been a 10% increase in the prevalence of obesity since 2005 through 2006, and there's been a 600% increase in the prevalence of obesity, severe obesity, since the mid-1980s. And we know this, and this is the reality, is that if we don't deal with obesity management, then that can lead to more and more health complications, including diabetes, heart disease, heart attack, stroke, and even some links with cancer. So without further ado, I'm going to start out introducing my guests today, and we're going to really try to break down some of the procedural approaches, but also still piggyback on some of the themes that we talked about last week. So my first guest is Dr. John Bull, and Dr. John Bull is a double board certified plastic surgeon who has been in private practice in Naperville, Illinois for over 15 years. Dr. Bull specializes in face, breast, and body procedures. The John Bull Center provides the highest quality plastic surgery and laser MediSpa treatments, where Dr. Bull and his staff are dedicated to helping their patients realize their aesthetic dreams. Please visit www.dupageplastics.com for more information, and I'm grateful to have Dr. John Bull here in his practice, serving as a silver level sponsor for today's show. So Dr. John Bull, he's to my right. Welcome to the show, Dr. Bull.
Thank you very much.
And
Glad to be here.
And Dr. Bull, so when I planned this show out, the guests today, I've thought of these guests in painstaking detail. I don't want to call it painstaking detail, but these are the guests that we've had a clinical relationship for my practice for a long time, so I wanted to get my distinguished guests on the show. So Dr. Bull, please tell us where you went to school, some of your training, and what's your thoughts, maybe some initial thoughts on the obesity epidemic.
Sure. I went to medical school at LSU in New Orleans, and then I did a 5-year general surgery residency at the Medical College of Georgia. I then came up to Chicago, went to Loyola for 3 years, and then second residency for plastic surgery. And we specialized after that in cosmetic surgery, but also in weight loss procedures, post-bariatric procedures, as well as massive weight loss patients. Not everyone has bariatric surgery that I treat, and we have a wide range starting from body contouring all the way through removal of large amounts of excess skin and fat.
Excellent. Thank you, Dr. Boole, for coming out today. My next guest is Dr. Ryan Headley, and Ryan and I met a couple of years ago, and he's been a great colleague. Him and his practice have really supported the patients in my medical practice as far as weight loss. So Dr. Ryan Headley is a surgeon and surgical bariatrician with Suburban Surgical Associates and the Suburban Metabolic Institute. You can check him out online at www.suburbansurge.com. Thanks for coming out, Dr. Headley. Please tell us a little bit about yourself and where you did your training, and kind of an initial thought on how you see the obesity epidemic.
Well, thanks for having me, Dr. G. I actually am from the area, originally grew up in the western suburbs, and then went down to college in central Illinois. Ultimately went out to the University of Iowa for medical school, and then returned to the University of Chicago for residency. And it was there that I learned how to be a general surgeon, as well as learned all the bariatric surgeries that are available. I've been in practice now for about 12 years, and then the last 4 years been going to Elmhurst, and that's where we've met. As far as obesity today, undoubtedly it's an epidemic, as you said. It really started tracking these numbers since the 80s, and it just quadrupled, quintupled since that time. And more importantly, what we're seeing are all the diseases associated with obesity. You mentioned the diabetes, obstructive sleep apnea, hypertension, ultimately leading to renal failure, all of these types of things that we're seeing in just epidemic proportions. And I think the aim nowadays is to treat those diseases and treat them as effectively as possible. What we found is through different medications, lifestyle modifications, surgeries, we're actually starting to have a profound effect on those diseases that are associated with obesity. So that's my primary focus at this point.
Excellent. Thanks for coming out today.
Thanks for having me.
And my last guest, I've known Dr. Darren Kastin for at least a decade. And Dr. Darren Kastin, he is just an amazing clinician. He really takes care of the patients that we send out his way, and the patients have a great clinical rapport with him. Dr. Kastin is a board-certified gastroenterologist and a recently board-certified in obesity medicine. So congratulations, Doc. He's with Suburban Gastroenterology Ltd. You can visit them at www.sgihealth.com. Welcome to the show, Dr. Kastin.
Well, thanks, Dr. G, for having me. Yeah, I was born and raised in Atlanta, so I'm a transplant out here. But I actually went to medical school right down the street from Dr. Boole at Tulane, and then ended up going up north to Yale in Connecticut for residency, and then came to Chicago to Northwestern for GI training. And as I've been out actually in practice is really where I've kind of developed that interest in obesity. You know, there isn't a state in this country that has a lower than 20% obesity rate, and the majority of the large number of states in this country are severely obese, as you stated earlier. So it's an extraordinary epidemic, and truthfully, I think people miscategorize obesity as a condition. It's really a disease, and if you look at it as a disease, a chronic disease that you can treat, and if you can improve that, we can substantially improve secondary diseases that develop, like obstructive sleep apnea, and fatty liver disease, and chronic acid reflux, and all the other coronary disease and all the other disorders that come associated as a consequence of obesity.
Thanks, Dr. Kastin, for coming on to the show. So what we're going to do today is we're going to talk about some of the procedural approaches. Again, last week we talked about some of the medical approaches and the lifestyle approaches to obesity management, but today we're going to be trying to layer on the foundation that we did last week. And again, for most people, I always tell people this, especially in my practice, number one, you gotta be intentional in your approach to life, and you gotta be intentional in your approach to health. So number one, have a healthy plan, have a balanced nutritional plan. Number two, we always strive for our patients to increase the amount and intensity of exercise. Number three, we just want people to stay motivated and on track. Nobody's perfect, but it turns out that when you have the resources needed for success, you can be successful in your health, and when you're having success in your health, you can have more success and enjoyment in your life. And lastly, practice healthy lifestyle habits. even those first few minutes in the morning that you get to yourself before you're on somebody else's time and somebody else's dollar, take those few moments for yourself. That really sets the tone for the day as you approach life, family, work, fitness, etc. So I really want people to understand you've got to be intentional on what these doctors are going to offer today are some pertinent points in helping you complement your efforts in weight loss. So when I think about weight loss approaches, yes, last week we talked about medical stuff, and this is what I'm going to ask my colleagues here to give me a little more input, because I'm going to be learning today as well. But we talked more about the medical approach, and now we're going to do more of the obesity-related procedures. So when I kind of done some of my prep work for this show, I've kind of broken them down into surgical approaches, endoscopic bariatric treatments, and then cosmetic. So I want to start out with the first question to Dr. Headley, who is a surgical bariatrician. And I guess what I want to ask you first, and this, maybe we can explain it to our listeners and our viewers, maybe in simple terms, what are some of the surgical approaches that are out there for individuals to deal with weight loss and things that you're doing on a day-to-day basis?
Sure, so bariatric surgery has actually been around for quite some time, going back at least 50 years, but I think probably in the last 15 years ago, it is really starting to become more refined. And early on, everyone was experimenting with bypassing portions of the intestines, making the stomach smaller, forcing people to eat less. And I think as time has gone on, we've actually started to address more of the metabolic issues, because it comes that it's more than just how much you're eating, how often you're eating. There are certain metabolic derangements that occur when someone becomes a certain degree of obesity that we need to address. And I think in the last really 15 years or so, we started to narrow in on this, and that's when we've seen the advent of some of the procedures that Dr. Kastin does, as well as some of the medications that have really come on the scene in the last 5-10 years. So to that end, the two primary operations that we're focusing on nowadays, one is called a gastric bypass, which has been around for 40 years, but has really been refined in the last 15 to 20 years. And then more recently, since about 2007, is a much more popular operation now called a sleeve gastrectomy. And the gastric bypass involves cutting across the stomach to make it smaller, and then bypassing a portion of the small intestine to affect the metabolism and kind of the absorption of food. A sleeve gastrectomy involves just cutting across the stomach to make it smaller, but what we found is that there is a metabolic effect when you look at some of the hormones that are released by the stomach that can help control hunger as well. So those are the two primary operations that are done by most bariatric surgeons. We do a couple other in lesser extent, and maybe about 10 or 15% of our operations are also revisional type operations where we're changing around things that may have been done in the 80s and 90s.
There was a procedure when I was going through medical school, Loyola procedure that was really popular at that time in the early 2000s, was the laparoscopic adjustable gastric banding in efforts to try to cause a restriction. But that really isn't done much anymore. Are you seeing that at all in your practice?
Not as much. It's a draft that you're going to say VBG. Vertical banded gastroplasty. The lap band is an interesting thing, and lap band is kind of the example of what I was saying, where we found that obesity is more than just intake and output. You know, the concept of a lap band was to wrap a silicone band around the top part of the stomach and physically restrict the amount of food that can go into the stomach, give people an early sense of fullness after eating small amounts of food, in hopes that they lost weight. And it sounded like a great idea. It was originally pretty hot in the 90s in Australia, and then came to the United States in the late 90s and early 2000s. And once it came on in the early 2000s, it took off like wildfire. Within 2-3 years, it was the most widely adopted procedure in the United States for obesity. And part of the reason for that was because gastric bypass had been around for many, many years, but in the 90s, everybody had horror stories about what was happening in gastric bypass, and celebrities were having the operations, sometimes having bad outcomes, so people were looking for an alternative, and they turned to the lap band. Now what we've seen is there are other alternatives, and there's increasing safety profile with the gastric bypass, such that the lap band is virtually fallen off, you know, the armamentarium of most bariatric surgeons. And as I tell my patients now, I certainly remove far more lap bands today than put in, and I haven't put in a lap band in about 3 or 4 years.
Wow, wow. It's amazing how we've progressed. Again, something that was like the it thing, and really has not really played a big role in today's management. And that's the one thing about medicine, as plenty of our listeners and viewers probably know, medicine evolves over the years. How we treat people today may be different than how we treat people tomorrow, but you're still approaching the same problem, because a lot of our chronic disease burdens have been around for a long time. We're just seeing an explosion, of course, in the obesity epidemic in the last 30 plus years in this country. One of the hormones that you were mentioning about was ghrelin, and it's interesting about the when we talk about the hunger hormones out there, we talk about leptin, we talk about ghrelin, and of course leptin being a way to kind of decrease the appetite, but it increases when you're fat or when you're overweight. But many obese people have a resistance to the appetite suppressing effects of leptin and its contrasting hormone being ghrelin, which obviously increases the appetite, increases people's appetite and plays a role in body weight. So, do you guys ever find any clinical use of measuring levels like this? I actually haven't checked to see if our lab does a ghrelin level, but our labs do leptin levels. Maybe Dr. Kastin, you might be able to comment on that? Or Dr.
I can
Headley?
tell you I've tried to order it, and I get pushback from the lab all the time. They go crazy when I order these tests about leptin or ghrelin. In terms of clinical utility, I don't think that there's much clinical utility in ordering these in the average patient. I mean, there are some very specialized type of disorders that might find it useful. There's a congenital form of leptin deficiency, and there are a couple of other disorders where checking leptin levels might help you clarify what you're dealing with. But in the average patient who is overweight or obese, checking these levels is probably not going to be very useful in terms of being able to make clinical decision making. The tough part about leptin is, yeah, you develop resistance as you gain weight, but as you lose weight, leptin levels start to drop again, and when they drop, the opposing ghrelin starts to go up and kind of drives the desire to eat again. So this hormonal drive, So you're really, your body's innate sense is to sort of protect whatever level of fat it has, thinking that that's a normal fat. And whenever you start to lose weight, your body thinks it's starving itself, and so it sort of drives you back up. That's a tough place to be. Yeah.
One of the things that Dr. Headley was mentioning about giving a little bit of a historical perspective on gastric bypass being around for a long time, I found an interesting thing, going back to another topic that we'll introduce in a few moments, but the data is really interesting, and I feel like sometimes it was, I don't want to say it was kind of trial and error, but things evolve, and the reality is that we have to try something as clinicians in order to see if it's going to work, and then study that, and if it doesn't work, then we try to make it better. What's your thoughts on that, Dr. Headley?
Without question. And I think that's the strength of the way we practice medicine, and that's the scientific method. You create an idea, and then you test it, and you say, this works, and then you go with that for a while, and then eventually you come up with a better idea, you test it, and it works. And I'd like to point out what you'd said earlier about the way we were doing things before. We've changed. And I tell all my patients today, hey, look, I'm telling you what is currently the state of the art and what we're doing today. 30 years from now, it may be different. And without question, it changes. And ghrelin. None of us knew what ghrelin was when we were in medical school. Right? Or leptin. I mean, that's new in the last 15 years. Yeah. It didn't even exist. And it's more complex than just ghrelin and leptin.
Right.
Certainly hunger and obesity is a complex disease, and I like the fact that you brought up that it truly is a disease and it's been identified as such now.
Yeah, excellent. I want to talk a little bit about this gastric balloon that people are coming to me and seeing me in the clinical setting, in a primary care setting. They say, oh, I don't want the permanency of true bariatric surgery. I don't want to be hospitalized for days on end, even though the length of stay has shown to improve dramatically over the last 15 years or so. But people always talk about, well, I saw this thing, it looks kind of sexy. They're doing it in Europe. They're doing these kind of things, and I can swallow something, or an endoscopist can put something down and inflate it into the size of a peach, and then I'll start losing weight. So it's interesting. I was finding doing a little historical stuff. The first endoscopic bariatric treatment, the gastric balloon, was done in 1985, and it was called the Guerin-Edwards gastric bubble, and it was the thing of the time at that time, 1985. Can you believe it? And here was the problem. Number one, it was taken off the market, but number one, it caused small bowel obstruction, and I'm sure Dr. Headley has seen plenty of cases of small bowel obstruction. and even us that aren't surgeons.
Fortunately, not from McGear and
Number two, it causes spontaneous deflation. So you inflate something, and all of a sudden it spontaneously deflates, and there's your chance of trying to lose weight kind of goes out the door. And then lastly, gastric mucosal injury. And I know Dr. Kastin, as an endoscopist, you've seen various causes of gastric mucosal injury. But it's interesting that was it. But it was cutting edge back then, and so we can't really fault it because that's the only thing that there was. Now we've got these newer cutting edge techniques, which drives me to, I want to talk with Dr. Bull about some of the cosmetic options that are out there for weight loss to complement. So I don't pretend to be a cosmetic surgeon. That's why I have Dr. Bull to help out with my patients and everything. But I still try to research a little bit. And so when I think about cosmetic approaches, I think about liposuction versus non-invasive fat reduction procedures. Can you give us a little bit of an understanding, just maybe start with like liposuction, and then we can talk a little bit about some of the non-invasive procedures for our listeners out there?
Sure. There's several different types of liposuction, but basically they all use a cannula to basically suction the fat from the subcutaneous space. It won't do anything for the fat inside or the omental fat that we see in really larger people, but it does help contour almost every patient that I see. There's a problem area that can be treated with a little bit of liposuction. And that's what we use that for mainly. It's not considered a major weight loss procedure. The maximum I can take safely is 5,000 cc's, which really doesn't weigh that much, but it makes a big difference if it's all coming from a specific area. So it does have its place in helping contour the body, but it's not a weight loss procedure. Some of the non-invasive treatments, there actually are lasers, but what we found that seems to work better is what's known as cryolipolysis. The major one in the industry is cool sculpting, where basically we place a suction cup over a protected area of skin, and it freezes the fat cells that your body slowly absorbs over about 3 months. And you can lose up to 22 to 25% of the fat in that area.
What are the differences as far as like cost from liposuction or recovery time versus compared to non-invasive procedures?
Right. Most of the non-invasive procedures, there's no downtime. You can literally finish the procedure, get dressed, and go to work same day, same hour. Liposuction, you're going to need a few days to recover from, and usually there's a little bit of drainage the first day, and you have to wear a compression garment for quite a bit of time to get the swelling out of the area where the fat was removed from. And that varies depending upon which technique and how much volume you're using.
Is there any, as far as you know, is there any, what you see, do you see equal results if you have somebody that comes in and says, hey, I want to do liposuction versus somebody that wants to just kind of do some of the non-invasive approaches, if you like maybe foul them out for 6 weeks or 8 weeks or things like that?
Well, I can do more in an hour with liposuction than I can with the non-invasive treatments in 3 months. If you're patient, you can get good results with the non-invasive treatments, but don't expect it to cost less.
That makes it, and that kind of gets down to some of the reality is even when we're talking about some of the procedures that even Dr. Headley does and Dr. Kastin getting to some things, and certainly from your perspective, Dr. Bull, yeah, there's a cost thing, and sometimes that may be a prohibitive effect to getting somebody through the door. We were talking on air, or we were talking off air, sorry, before we started the show, and I was mentioning with Dr. Headley that I was doing some research. It was published in an Obesity Surgery Journal in 2013, and talked about how less than 1% of eligible patients that could get weight loss surgery actually get it. And I was telling him, I go, wow, that number is just mind-boggling from my perspective as a primary care doctor, and it kind of says, holy smokes, I need to do better from my end on getting my patients that have those multiple risk factors, and they qualify. They've got the severe obesity, plus the diabetes, plus the other comorbidities, and maybe I need to just take more time myself to say, hey, I know we're talking about your joint pain, I know we're talking about some of your stressors and things like that, but I need to challenge myself, and I think that's one of the barriers. What are some of the barriers? I'm going to ask Dr. Kastin this question. What are some barriers that you see when it comes to dealing with patients that may have some trouble in forming a good weight loss plan?
Well, one thing is probably just lack of education. Patients, I think as clinicians, it's our responsibility to inform patients and educate them in a manner that they understand, and then present to them a program or plan that they can implement. And the problem is that I think a lot of clinicians either don't want to engage in that conversation, maybe they find that it's too difficult a conversation topic because talking about weight issues with patients is a sensitive issue, patients are sensitive to it, or maybe they just don't have the personal fund of knowledge to be able to convey to the patients, so the patients don't actually get educated about that. The other issue is that there may be concerns about insurance coverage. There may be the patients may not be interested in it. They may want to lose the weight, but they may not want to make the change to do that. Which we often find is how do I do this and how do I do it quickly? I don't really want to make any changes to my lifestyle. I just want to lose the weight. So that becomes a challenge. You actually have to re-educate the patients to kind of get them to kind of change the culture of how this process should happen. And then you need to provide a structure, and you need to provide resources for them so that they have a place to come back to when they start to make some progress.
It's interesting. I'm kind of chuckling a little bit because I think when I see my practice and people want that, as a society we want things fast. That's just how we live. And I go, I have one word for you: phentermine. Which is an FDA-approved weight loss medicine. But it's interesting that we want certain things now. But obesity is a very complex condition. It's a multi-system disorder, and you have to have that patience to deal with things, to deal with this, and have a plan that it may take you. It didn't take you 3 days to put on all that weight. It took you a long time to put on all that weight. It's going to take you quite some time to take it off. Dr. Headley, when you see patients kind of post-op, how much, and it probably differs from person to person, but how much weight loss would somebody maybe think they would get, or when you counsel your patients, do you tell them how much weight loss you may be expected to get if you're following through a plan at certain time frames, maybe 1 month, 3 months, 6 months, 12 months?
Well, undoubtedly, everybody's a little bit different, and a big component of it is how big they are to begin with. So someone that's very large, someone that's in excess of 500 pounds, can easily drop 100 pounds in 4 months, easily. However, someone that is 230 pounds, it's going to go much more slowly, maybe 10 pounds a month. Inevitably, if you look at both patient populations, they all think they're not losing it fast enough regardless. So it's the one common thread.
Right. Always.
And they continually come in and say, I just don't think it's coming off fast enough. That said, everyone will also experience a plateau regardless of which weight loss method they're pursuing, or the different methods that they're pursuing, whether it's medical things, surgical things, diet, exercise. Everybody, the natural history is to experience a plateau during their weight loss journey. And it's important to talk them through that. I can't underscore enough the importance of the education part that Dr. Kastin brought apart. That is the biggest hurdle when it comes to getting people in the door to address this type of thing. And another big part of it is combating what they've already learned and what they see in the media. One of the most difficult things to combat is things that folks already think is healthy. So one of my favorite stories is a patient that came in and she'd gained a significant amount of weight in a month. And I said, well, what's been going on? And she was absolutely dumbfounded because she had told me that she'd begun shopping at Whole Foods, and she couldn't understand how she had gained the weight by eating foods that she had purchased at Whole Foods. It just goes to show that regardless whether it's organic or all natural, it doesn't matter.
Yeah, you're absolutely right. It can be a challenge, it can be discouraging, and certainly. I know one of the things that I get a lot in my practice is, hey doc, I feel great, I just can't lose this pooch that I have. I can't get this midsection, this stubborn belly fat. And I usually have to take a moment back and say, first of all, in a primary care setting, the role of primary care physician is to make sure you're not dying. That's what I kind of told basically. We got to stop. Let's make sure you get a physical, step one, see some numbers. Let's get an A1C, let's get some BMI, let's get up our blood pressure. So you can't just go like, hey, I want to start losing weight without making sure that you're not breaking down. Maybe there's a metabolic issue, maybe there's a hormonal issue like hypothyroidism affecting somebody's ability to lose weight, or maybe there are other issues, stress, and feeling overwhelmed, which has certainly a big role in trying to support somebody through behavioral changes for weight loss. But the big thing that I get all the time is, how do I lose this stubborn belly fat? And my answer is usually, I try to break it down, I go, well, there's two types of fat. We all want to lose the midsection a little bit. We have the subcutaneous fat, that's the kind that you pinch. You know, we can all probably just touch our sides right now and grab onto a little bit of something. And then of course we have the visceral fat, and that was something that Dr. Bull had mentioned when he's doing his liposuction procedures to really attack some of the subcutaneous fat versus that visceral fat, which is the deeper fat around the organs, and we kind of also call it active fat, and that's the kind of fat that can lead to interfering with liver function, interfering with hormonal functions, leading to insulin resistance and diabetes, leading to dyslipidemias, leading to blood pressure issues, leading to a ton of other things, producing hormones like cortisol that is destructive to the body, and then next thing you know, we have our weight challenges. How do you guys approach, and maybe I'll ask Dr. Kastin this first, how do you approach like the patients that may come in and see you and say, hey, you know, I can't get rid of this belly fat. What are some of the techniques that you advise them at that time?
Well, you know, I think the first step is to kind of have the patient take a step back from that, and not be focused on, you know, specifically, you know, I can see the visible fat. Is to take a look at the entire dynamic and show them some of the areas where we may see a distinction in lab values that might actually reflect whether or not they have fat that's also deeper that actually comes with greater consequence, like fat in the liver causing abnormal liver inflammation. And when you show them that, and you explain to them the nature of that sick fat, if you will, you know, then it starts to actually make an impact for them. They start to understand that. And then you got to get on the same page with them. You got to ask them if they are ready to start making a change, because quite frankly, you know, medications for weight loss really only help if the patients are already changing the nature of how they're eating. And I really don't call it a lifestyle change anymore. I actually start to tell them I need to reteach them how to eat. Because if they can change the chemical makeup of what they're eating, that weight will come off, and then they'll start seeing that the belly fat goes down. You know, the benefit of bariatric surgery that Dr. Headley does is that it changes body physiology. It doesn't just create restriction; it actually changes internal chemistry, which has a lasting effect. And if you're not doing it in a surgical manner, then you have to find another way. And even with surgery, you still have to make a lot of change in terms of the chemical makeup of what you're eating, and incorporate other good habits into that, including physical activity and other factors. So I think it all goes back to education. It all goes back to asking the patient if they're ready to make a change, and then showing them where the changes have to be made in order to accomplish, to be successful. And then you have to keep reinforcing it, because you know they'll fall off the wagon from time to time, and you got to be there to kind of help get them back on.
The follow-up, without a doubt. I'm going to take this section of the show is brought to you by the John Bull Center of Plastic Surgery. Dr. John Bull is a double board certified plastic surgeon who has been in private practice in Naperville for Illinois for 15 years. Dr. Bull specializes in face, breast, and body procedures. The John Bull Center provides the highest quality plastic surgery and laser MediSpa treatments, where Dr. Bull and his staff are dedicated to helping their patients realize their aesthetic dreams. Please visit www.dupageplastics.com for more information. So I want to ask Dr. Bull this last question. We're going to change topics a little bit. When you see patients, because it's only from a cosmetic standpoint, you want to have a good result. I mean, a lot of times patients are paying cash, their hard-earned money, to get that look, that shape. But how important for you is, when you see them as a clinician, how important do you lay out the facts and say, hey, this isn't going to work unless you do this and this. I can only do so much.
Oh, I say that every day, pretty much to every patient. There are certain ones that they really do have just a stubborn area, and they're doing all the right things, and that's fine. But the majority of them are going to have to work at it and continue it. I can take the weight off, or the contour that they want, give them the contour they want, but they're going to have to maintain it. So that's where it works hand in hand with the weight loss centers and you primarily, primary care doctors that see people and stay on them about maintaining their weight, their diet, their exercise. And it's not just that, there's a lot more to it, as you guys mentioned.
Excellent. No, thank you for your commentary on this important issue. So what I want to do now is I want to take a more of a kind of a global look on things, and I challenged the panelists last week on some of the roles that we have. And so those of you that have been tuned in so far, you've heard a lot of different techniques that are out there by our distinguished guests today on some of the techniques they incorporate into their clinical practices on a daily basis to help to combat the obesity epidemic. I don't want to take a bigger, more conceptual, holistic approach to this. So I'm going to ask Dr. Kastin this question. What is the role of government? I'm not trying to cause controversy, guys. Oh, yeah, I said government. All of a sudden, everybody goes, "Oh my goodness!" Is that government? Government? Oh no! Better be careful what you're saying.
Turn up.
Yeah. I'll restate the question. No, but what is the goal? What is the role of government in tackling the obesity epidemic? And you can. I know it's a very broad question. You know, we have things at the local level, the state level, the national level. But is there a role that the government has, maybe at all levels, of tackling the obesity epidemic?
Well, I mean, you know, back in the 80s and 90s, you know, there were big campaigns about don't do drugs and smoking cessation, and you know, all these big government-sponsored campaigns, and I think that that the government could actually engage in a campaign for obesity. I mean, it is epidemic in this country, and there's no question that federal and state and local governments should want to do that, because I mean, when you know, there is every couple of years we're having more debates about healthcare costs and how to reduce that, and the answer is really staring us right in the face. You know, if we created better global information to our population about obesity, I think that we would actually see more than less than 1% of patients who are potential surgical candidates, you know, getting surgery, and of the 80 million you know, people in the country who you know, suffer from obesity, more of them would come in to see our doctors, asking them, you know, how do they improve that, and I think that is certainly a government role. I think that's central.
Dr. Headley, your thoughts on maybe what is a role of government, whether it's local, state, or federal, as far as handling this obesity epidemic to support the hardworking clinicians that are trying to help out?
Sure. Well, I love what you said about the education. I agree. If we can have a war on drugs, then undoubtedly we can have a war on obesity. And just public information. That's the first component to it, getting the message out there. The second component to it is easy access to care. Okay, currently there's restrictions in place that certain Medicare patients can't have these types of operations, this type of care, or receive these types of drugs. Okay, Medicaid population is the same thing. And then there's commercial insurance restrictions placed upon these types of operations, procedures. So I think you start to reduce the regulation on that, or regulate it in a way such that more people now have access to it. I think those are the two primary: ease the access and increase the education.
I like that access component, and I know one of the things I was researching for this is there was a study published in 2012 and 2013, and it actually looked at Medicare claims data from 2011. And in 2011, Medicare came out and said, hey, we're going to start paying for obesity counseling. And at that time, Medicare came out in 2011 and said, we will pay for weekly obesity counseling visits times 1 month, then bi-weekly visits for months 2 through 6, and then monthly visits thereafter, months 7 and thereon. However, when they published, and this published was actually quoted the wrong year, it was looking at Medicare claims data from 2012 to 2013, but the study was published in 2016, and the Journal of Obesity showed that fewer than 1% of eligible patients received this kind of counseling in the past. And you kind of look back and say, holy smokes, we're not doing a good job. We can do a better job. And when you have people that are dealing with obesity and we don't offer them the resources, and in terms of that, a lot of times patients may want you to go ahead and say something versus assuming that they know they're working on something. In terms of that, patients that know, we always believe in being upfront with our patients, and I know everybody on this panel believes in being upfront. The more you're upfront with people, the more they're likely to do something. And you know, the old saying, call them out, but not in a demeaning way. We're just trying to have a supporting way to help people say, hey, we understand that this is one of the many particular issues that you're dealing with, but those individuals that that at least have that conversation with their clinician, with their physician, are more likely to be successful and engage in that behavior. Dr. Bull, what's your thought on just kind of the role of where we're at federally? I mean, you know, what's the role of the government as far as helping us out dealing with the obesity epidemic?
I'd definitely like to see more. Public education is key, and the counseling, you know. I wasn't even aware that they could offer that counseling and have it covered.
Now, I wasn't aware until I started researching for this show, and it's been out since 2011. So we need to do a better job of educating clinicians.
And then, yes, letting us know what's available so that we can help everyone.
Absolutely, and going back to what Dr. Headley said, access and equity in that access as well too. That's important to deal with these epidemics. I want to ask the next question. So, is there a role of pharma? Ooh, controversial. Given we got government, got pharma. What is the role of pharma out there? Maybe from a corporation in helping to tackle the obesity epidemic. Certainly, there are FDA-approved medicines made by pharma to help out. There are procedures that are FDA-approved, devices that are approved that made by companies to help us out. Do they have a big role in the playground of obesity management? I'll start with Dr. Headley on that one. What is their role, if any, or should they have a role?
They do have a role, and I guess, for lack of a better term, I'd probably say it's a necessary evil, or potentially a necessary evil. A lot of the discoveries are made based upon the drive for profit, you know, frankly.
That was a nice way of saying that. I wasn't sure how I was going to phrase that.
And you know, just like in anything in America, if there's money to be made doing something, people will do it, and then they'll do it better. And the same thing holds true with medications, whether it's a cancer medication, whether it's a pain medication, whether it's a treatment for obesity. So there is a role, but it's a dual-edged sword, you know. And with that comes great discoveries, but you know, it's at the price of profit and capitalism, and then you get into the whole argument of access to care, and some people frankly can't afford some of these great discoveries. So it's a difficult thing, and I don't know how to rein it in necessarily. I mean, we definitely need it, but it's a tough one.
Dr. Kastin, what's your thought on pharma in general, pharmaceutical companies helping clinicians in this process, or becoming big stakeholders in the obesity management?
Well, I think that pharma and insurance are kind of linked together because patients get their medications through insurance coverage. That's how they are able to afford them most of the time. And I think that making these medications affordable is first and foremost. So pharma certainly plays a role there, and obviously, you know, I agree with Dr. Headley. You know, the success in developing new drugs is going to be kind of linked to their ability to benefit economically from that their companies, and that's fine with me if it produces good quality medications that provide benefit to our patients. But then making them accessible, so maybe taking less of a profit might be helpful. You know, the other issue is, you know, whether it's government or insurance or both, you know, there's still perspective that obesity is a condition, not a disease. And so what happens is they limit the amount of time that you can actually take these medications. Phentermine, this medically approved weight loss medication you mentioned earlier, that it's only approved for 3 months. But these patients may need to be on it lifelong. So that makes it pretty difficult too.
Excellent. I'm going to ask the next question to Dr. Bull and put him on the spot. Why not? What are some of the, you know, let me rephrase the question. We as practitioners can do better, clearly, in managing obesity. We as clinicians are critical of ourselves. We're taught to be critical thinkers, independent thinkers as well too, and also the scientific method. If it works, great. If it doesn't work, you try to figure out why it doesn't work and then apply it again. So as we kind of look at aim the camera on ourselves, what can we do as clinicians to better engage our patients or to do better in helping address the obesity epidemic?
That's a tough one because it's multifactorial, but I think the most important thing is to follow up with the patients, stay on them, and hold them accountable to the changes they've agreed to make. And if we can get that and get them to take the medicine, get them to agree to an exercise plan, and I hate to use the word diet, but a change in what they're doing with their current diet. That's the most important.
Thank you. Dr. Kastin, what are your thoughts about what can we do better as clinicians to tackle this, you know, physicians are very much leaders in what we do, and what can we do better as physicians to help tackle this epidemic, in your opinion?
Well, the first thing might actually start in the waiting room. You know, patients who are overweight or suffer from severe weight problems may not even show up to the doctor just because the chairs that are provided in the waiting room aren't large enough to fit them, so they feel embarrassed. The second thing is, I think that the physicians who are seeing them, from the primary care to the specialists, need to make them feel comfortable that their weight is not necessarily their fault. You know, it may be a consequence of multiple factors, and I think that that we need to make a nurturing and comfortable environment so that they can actually have an open discussion and not feel that they're being judged or stigmatized.
Dr. Headley, I'll ask you that same question. You know, you have a unique perspective from, certainly you may get patients as they're down the line, they've already maybe gone through maybe medical weight loss, a medical bariatrician or their primary care doctor, and then they get to you because maybe they're at the end of the line. But what are some things that you can do better, or that we, in general, not saying you as a person, but in general as physicians, what can we do better from your perspective in helping to tackle the obesity epidemic?
I think that we, as all physicians, could do a better job as far as tackling this by the way in which we communicate with patients. You know, we as doctors have been trained kind of like scientists, and it's very easy for us to get fixated on hemoglobin A1C levels, cholesterol levels, and high blood pressure. And we look at those numbers, and we're good at addressing those numbers. But what we need to get better at is addressing how those numbers are affecting these people, and provide examples, real-life examples for patients to key in on, say, oh yeah, okay, that does make a big difference. Me being obese is making it difficult for me to get in and out of the car, to walk on ice, to go to the movies, to fly in airplanes, all these type of lifestyle type of activities. I assume that Dr. Bull is probably more keyed in on those types of things and talking about lifestyle and its effect on you outside of the numbers and things that we focus on. And we could probably take a lesson from him in that regard.
I agree, and the fact that we should be using each other as support, and that's one of the reasons why I wanted you guys from different backgrounds to come today and talk about that the management of obesity, it has to be multidisciplinary, without a doubt, from your gastroenterologist, your surgeons, your cosmetic, if we need it, if our nutritionists, we have to have a community to manage this growing problem. So speaking of community and things like that, social media, we're using it a lot. What do you guys see? I know from my end, I have patients that come in there. They have walking step tracking apps. They're wearing the what I call the wearable, the swag on their wrists. And do you guys see a role at all in Dr. Bullis? Do you see a role at all in technology in trying to help tackle the obesity epidemic?
Absolutely. Starting with Fitbit and all of the other apps that came around, people felt accountable, and then their friends knew what they'd actually done because it's out there in social media. So now it's a competition, and that has actually become fun for some people, but it can also deter others from doing it at all. So it's a fine line, but the majority of it is positive.
Dr. Kastin, do you recommend your patients to use any apps that are out there, taking advantage of some of the technology and your approach to obesity management?
They're usually recommending apps to me.
I agree. Doc, have you seen this new thing? Doc, you got to get your head out of the
They're
book.
usually coming in with this stuff already.
Yeah.
So, I haven't specifically, but mostly because I think that patients' first starting point is, I need to exercise, so the first thing I'm going to do is join a gym, or I'm going to buy a Fitbit. And I think patients need to understand that exercising really doesn't affect much weight loss. Maybe you can lose about 6-7 pounds from exercise, but exercise is really designed to improve cardiovascular health and to maintain weight that's already been lost through other means. So I think that the technology will continue to get better, but perhaps being able to use that technology to track weight may actually be helpful for an individual. I think that most of them already are on it. They're already perfectly aware of the technology that's available, and they're usually coming in with more technology than I've even seen.
Dr. Headley, do you see any tech use in your practice or patients coming in and trying to help complement their efforts? I know you see it from a surgical perspective, but you're also counseling them on lifestyle as well.
Yeah, I see it, and similar to Dr. Kastin, I think it's more them teaching me about it. I'm still kind of a pen and paper kind of guy. But my fitness pal, we see a lot, the Fitbit things. But at the end of the day, there's no secret, there's no magic here with what we're talking about. In the latest tech application, the fanciest sneakers, none of that is going to make you lose weight. You just need to make that decision to change your lifestyle. And really, at the end of the day, nothing else is going to do it.
They do have some in there that have a diet plan and shows what you eat. Those, as well as, what was the last one?
Second
My
click
Fitness Trainer.
education.
You have to put in what you eat, so, and how many calories you burned, and that process actually has been very interesting, and it does hold people accountable,
It does that.
which is the hardest part.
I wanted to tell a funny story real quick that I too was caught up in the rise of the tech for meal tracking, for example. And I remember my wife and I went on a vacation to San Diego, and I'm sitting there at a restaurant, and we got a great view and everything, and you can see the water, and you got the beach, and we're having dinner, and there I am, like, on my phone, typing in, like, chicken cacciatore and trying to find it. My wife's like, put that phone down. And I go, well, I'm trying to track what I'm doing, but I can't find it here. I'm spelling it wrong, so that became too cumbersome, and then I stopped doing the meal planning that way. So it's just kind of a funny story. Guys, just reminded my memory on that. Well, what I want to do, we got about 5 minutes left, so what I want to do at the end of the show, we always kind of have the assessment and plan. In medicine, of course, when we see somebody come into our office, we call that the chief complaint, why they're there, and then of course we as physicians, we call it an assessment and plan to kind of summarize where we're at. So I'm going to kind of do this as a final thoughts approach. So I'm going to ask our guests here today to kind of give me and our listeners out there a few takeaway points, just something that's tangible, something that they can do today to inspire them to make those changes, to never give up. So I'm going to start with Dr. Kastin. If you had to give me like just a couple of takeaway points on obesity or encouraging behaviors, what would be your take-home points for our listeners out there?
This is what I tell my patients at the start. The first thing I tell them is that it's not entirely their fault. It's not just a behavior. There are other factors that are out of their control. So what I try to encourage them to do at the start is to make sure that they're getting enough sleep, because if you're getting less than 5 hours of sleep or more than 9 hours of continuous sleep a night, you're actually at risk for weight gain. So make sure you're getting a good night's sleep. I try to make sure they're getting enough protein, breakfast, lunch, and dinner, because protein actually tends to be an appetite suppressant. Make sure they're getting plenty of water. And I think that is generally a starting point for those patients. And I think that there's a lot more to discuss. I'd like to see my patients just starting the process of physical activity. Some of them suffer from such weight issues that they really have a hard time, just simply walking. But even if you can walk 30 minutes, just a casual walk 30 minutes for 5 days a week, that actually it will improve their own personal sense of well-being, and it'll create a sense of motivation. And then it's a close follow-up in the next steps.
Dr. Headley, final thoughts for our listeners and our viewers out there on this topic of obesity?
I guess when I first meet a patient, I try and take a stock of what's going on with them right now, what their goals are. So I ask them, where do they see themselves now? Where do they want to be, and what are they willing to do to get there? Oftentimes, people think that they're eating and living a healthier life than they truly are. So to document that, I'll have them start writing down everything that they're actually eating, keep what I call a food journal, and then bring it back in for review at the next visit and go over each meal step by step and say, this is good, this is bad, more of this, less of that. Again, focusing on the high protein, low carbohydrate type meals. And then seeing what their overall goals are and how realistic those goals are. And then that plays in with what Dr. Bull said. A lot of what we do as physicians is management of expectations. And there's a component of that as well.
Dr. Bull, final thoughts on the topic of the day?
Don't give up on your goals. We're here to help. We're all here to help. And there are multiple ways to get there. And just because you didn't make it that first time, don't give up. Keep trying. And we're here to help in any way we can. Even if it's massive weight loss patients, after they've lost the weight, they still have extra excess skin that bothers them just as much as the weight did, that's treatable. I can take care of that. There are other issues along the way. These guys can do a better job at than I am. So don't give up. We're here.
Excellent. My final thoughts are just a few things. Number one, be intentional. Have a ritual. Have a schedule of something that you're going to do. Sometimes going from point A to point B can seem so insurmountable. It can be so overwhelming. And really going from point A to point B is not necessarily a straight line for everybody. There may be bumps in the road, but small steps are worth it. And I guarantee you, if you follow those small steps, you'll be successful with your health and in your life. I want to thank my guests today. We got Dr. John Bull, plastic and reconstructive surgeon from the John Bull Center for Cosmetic Surgery and Laser MediSpa at www.dupageplastics.com. We've got Dr. Ryan Headley, surgeon and surgical bariatrician from Suburban Surgical Associates, Suburban Metabolic Institute, www.suburbansurge.com. And lastly, my guest, good friend and guest, Dr. Darren Kastin, gastroenterologist, and recently board certified obesity medicine expert from Suburban Gastroenterology Ltd in Naperville, www.sgihealth.com. Thank you to our silver level sponsor again, the John Bull Center for Cosmetic Surgery and Laser MediSpa. I am Dr. Mark Gomez. Check me out on Facebook, Instagram, and Twitter at To Your Health. Dr. G, check me out on my website, www.drmarkgomez.com. Next week, we're going to be talking about the opioid epidemic. Peace out, everybody. Bye-bye.
Thank you very much.
Great show. We can come back and talk about that opioid thing if you want. We got some strong